5, 4, 3, 2.
Welcome to Westchester Jewish Community Services. As a leading agency in providing a comprehensive spectrum of human services, we have been helping people since 1943. We serve all people in Westchester County, regardless of age, income, or ethnicity. We provide a wide variety of essential and dynamic services that make a difference in people's lives. Children, teens, adults, and senior citizens are served by our network of programs located throughout the county. When people come to us for assistance, they become part of the WJCS family. Our highly trained and skilled staff focus on you and your family and are committed to becoming your partner in finding solutions. For more than half a century, we have been connecting people to services that help them overcome mental, physical, or emotional challenges. WJCS is here in your community when you need us.
Welcome to the Ways We Care of Westchester Jewish Community Services. I'm Dale Wang, Director of Community Relations. WJCS is funded by government grants, UJA Federation, United Way, private individuals, foundations, and corporations. I hope you bear with me tonight because I'm suffering with a little bit of laryngitis, so I'll try my best to make myself heard. Families today are barraged with conflicting messages and realities. There is evidence of increased depression and suicide among children and teenagers. Young people are experiencing more societal stressors from homes, schools, and their environments, and many are showing less ability to cope with their anxieties and emotional challenges. Parents who recognize the problems their children exhibit may also be experiencing increased stresses, economic, social, and physical, and are also more exposed than ever before to media advertising that promotes medications as cures for whatever ails us. Ask your doctor about is probably the most common expression on TV commercials today. Yet for those parents who look to drugs to alleviate psychological conditions like depression and anxiety, there have been recent reports that have cast doubts and questions about the safety of these medications, especially for teenagers. What's a parent to do? How do we determine when a child is clinically depressed or dangerously antisocial? And if we suspect that a child needs professional help, what is the appropriate course of action? Tonight we are going to speak with several WJCS clinicians who will outline the issues for families about childhood and adolescent depression and help people understand the treatment options and risks. Of course, every child is different and faces unique and individual situations. This discussion is intended only to help parents understand when a child may be at risk and to help evaluate the possibilities for treatment in light of recent research and alerts. You are always encouraged to ask your doctor. So, given that introduction, I'd like to introduce Dr. Leslie Bogan, who is a chief psychologist at WJCS. Welcome, Leslie. Dr. Margarita Munoz-Dumet, who is a child psychiatrist with WJCS. Welcome, Dr. Margarita. And Andrew Levin, who is our medical director. Welcome. I'm going to call you all by your first names if you don't mind. With all these doctors, it's too hard. So, in our second half, we'll be speaking with a parent who has actually dealt with bouts of depression and psychological issues with her child. But in the meantime, it's very confusing and daunting to be a parent whose child suffers with emotional and mental issues today. Leslie, I was reading some research that you had done. According to statistics, it looks like teenage depression is more common than ever. Why is that? And what accounts for this perhaps rise in teenage depression?
I suspect that kids now have pressures that they have never used to face in the past. We live in a time of accelerated demands. I think that the pressures that you described that the parents are feeling are also translated down to the next generation.
Right, so it seems that there is more depression, or are we doing a better job at identifying depression among young people?
Dale, you know, this is very interesting because several decades ago it was noticed that since World War II, there are more people with depression throughout the population. And people really don't understand this. It might have to do with family dislocation or more pressures, faster lifestyle. So we don't really understand why that is across the whole population. I think that we are much better at identifying it. We have done a good job of educating general practitioners, of educating teachers, of educating all kinds of professionals to be on the lookout, because these are serious syndromes in children and adolescents.
Mm-hmm. What are the signs that makes a child that's a difference between normal sadness and clinical depression? What do you see?
It's basically a level of dysfunction. And basically you're looking for dysfunction in an important area like school or home functioning, along with certain symptoms that would cause a clinical depression. It has to be consistent through time. So a child who gets depressed for a day or two is not clinically depressed. That can happen normally during adolescence. But a child that's depressed for at least a week or two and it's causing some dysfunction in their daily lives should be evaluated for a clinical depression.
Mm-hmm. So what would be the signs? What would you pick up from a child, especially, I guess, starting with a young child and then we can move to the adolescent? What would parents see that would make them say, I think my child really has a problem. He's just not being himself. He's just not sad. There's really a problem.
Well, unfortunately, parents are not the best at identifying depression in their children. Depression is part of internalizing disorders, and as opposed to ADHD or disruptive disorders, parents are often the last ones to pick up on it. Children are more apt to confide with a friend, sometimes even a school counselor, unless they have a very open and direct relationship with the parent, and the parent actually seeks out looking into the situation. Lots of times you can see not just sadness, but irritability. You can see social withdrawal. They're not going out as much. They don't seem to be enjoying the same activities. Their grades may be slipping or dropping. There may be changes in sleep or appetite. In severe cases, letters of hopelessness can be found sometimes in diaries or to peers. Mm-hmm.
So if a parent isn't necessarily the best reporter, are we likely to hear from teachers? And
Unfortunately, that's often the case, that sometimes it could be a friend who might go to a parent or tell the child, you know, you're not acting like yourself. Mm-hmm. You know, if a parent has a very open relationship and has open communication with their child, the child may actually discuss it. But if the parent feels stressed, they may try to hide that from the parent because they don't want to increase the parent's stress. Kids, especially young kids, feel very responsible for everything that's going on. So if they're in the midst of a divorce or a marital discord or financial stress, a child may withhold that information from a parent.
Mm-hmm. Leslie, how is it different with adolescents?
Adolescents, I think it's even harder to determine because I think the normal state of adolescence is a certain amount of moodiness and mood dysregulation. So I think it's even harder to determine it in an adolescent than in a child. It looks somewhat the same as what Marguerite described. It would be things like changes in behavior patterns, withdrawing from friends, changes in school performance, Again, irritability is something that's really a hallmark of child and adolescent depression that you don't see so much in adults. Moodiness, crying jags, and in discussion, it's the sense of hopelessness and despair that is significant.
Mm-hmm. Now, one of the things I think that struck me as being so difficult about working with children and understanding the issues is that they keep changing. That the maturation process also changes what goes on and hormonally and developmentally. How does this affect how they appear with regard to their mental health issues?
Well, I think that both of you point out that children are not just little adults, and that in order to understand how a child is functioning and whether they are suffering from depression or anxiety, you have to understand how a child should be functioning in approximately that phase of his or her life. And that's really what's important is we used to just look at children and expect them to be like adults, but now we understand the interaction between these things and their development.
Mm-hmm.
And often you do see regression in children, too, that are depressed. So they might have developmentally gone back to another stage. For example, a very young child may want to sleep with mommy and daddy after they had been sleeping in their own bed. Or, you know, for anxiety, you might see something like bedwetting reoccur.
Mm-hmm. So going back to previous developmental
Right.
stages and things that wouldn't be developmentally normal.
Right.
Right. Is the incidence of depression, from what you see, greater in one socioeconomic or cultural group, or just different among groups? Is this something you're able to speak to?
I would say each socioeconomic group has its own stressors. Financial stressors in the lower socioeconomic groups, lack of support. But in the higher socioeconomic groups, I think the children have a lot more academic stressors. There's a lot more focus on that. The cultural, the social aspect, there's a lot more pressure on the kids to be very socially active. So the pressures may be different, but I think they have the same impact on the children.
Mm-hmm. Do you see the same things across cultural and socioeconomic?
Yes, and I'm
groups?
not aware of any research that suggests that among children, depression is more common in any particular socioeconomic group, and I don't think that I've observed that either. Have you,
No.
Andrew?
So we're really dealing with something that impacts children at all stages and basically in all communities in our county.
Oh, yes.
If school personnel or family members or friends recognize these signs, what steps should be taken to help determine the appropriate treatment for a child with depression or an adolescent with depression? Andrew, what steps should someone start?
Well, I guess it depends on sort of who's making the observation. A parent, for example, the first important thing is really to know your child and to be involved in your child's life and really have an understanding of what's going on as best you're able to. Talking to teachers, maybe having your child talk to the school counselor, maybe talking to your pediatrician. I mean, there are a variety of different routes. In terms of teachers, I think maybe you could tell us about how would teachers go first for a counselor, or maybe teachers would speak to a parent?
My guess is the teacher would first go to personnel within the school,
Yes.
either a social worker or a school psychologist. And then if they're concerned, they're likely to involve the family. I mean, that would be the next step.
Mm-hmm. And what would be the progression for assessment and for determining treatment for a young child, and then we'll deal with the adolescent?
Well, I think once the teacher has determined that there's an issue, she would consult with the school psychologist or the school social worker, who would then probably meet with the child, and then after that meeting discuss it with the parents. And at that meeting they may make a recommendation for a psychiatric assessment which is more thorough at that point if they feel there's a degree of impairment.
Okay. And what types of things go into a psychiatric assessment?
Well, I think that, from that stage where it's identified in the community, then a professional gets involved who may be a mental health professional in an agency or a clinic or a private practitioner, and they really undertake a thorough evaluation both of the child and also speaking with the parents and the school. I think one of the key issues when you're working with children and adolescents is to gather information from these 3 different sources, because you can't put together a full picture without that, and that's often the error that's made.
Mm-hmm. So once a psychiatric assessment is made, and would the same thing go on for an adolescent necessarily?
Yes.
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 Okay, so once that psychiatric assessment is made, how is treatment determined? I mean, we're reading a great deal about medication these days, and when I opened, I talked about parents hearing about medications and hearing the advertising for medication. And it seems that people think medication's a cure-all for everything, and yet recently the FDA put some stops on what you can use for depression with children. So how do parents navigate this?
I think the first principle, when we were talking about this show last week, the first principle is how bad is it? What is the level of impairment and severity? In what ways is the child or adolescent not functioning? Is the child or adolescent in some kind of danger? Because a small percentage of kids with depression may feel quite hopeless and might represent a danger to themselves, over the short run especially. Once you have some idea about the severity, then you can decide on the type of treatment. I think that we as a community favor talking treatments as an initial step. Unless the child is so ill that we feel we need to combine a talking treatment with a medication. But I think our first goal is to use some kind of verbal treatment.
Can you give parents a little bit of an idea of what talking treatment and behavioral therapy involves, and how that begins to address some of those issues of depression in children?
I think that the research at this point supports cognitive behavioral therapy rather than the more traditional psychodynamically oriented therapy from years past. And CBT treatment for depression has two streams that come together. One is the cognitive component, meaning that you help the child to change his or her thinking patterns so that they are more productive and less likely to continue the depression. The other piece is behavioral, where you help the child to take steps to, again, break out of the cycle of depression. So if the child is withdrawing and is no longer engaging in pleasurable activities, you might give the child an assignment over the week that he or she has to begin to re-engage in those activities. So those are the 2 legs of cognitive behavioral treatment that have been found most effective CBT for childhood and adolescent depression.
Mm-hmm. Okay. Margarita, how about when you work with young children? Because I think it probably is...
You could use CBT or cognitive behavioral therapy for very young children, but their thinking is very concrete. So you would really tailor that toward what their developmental age is. So you might use techniques that are much more concrete, like, first helping them to identify what their emotion is, what their pattern of thinking is, and what their actions are. And you could turn that into a game and give them little homework assignments, like next time when you get upset, instead of withdrawing and locking yourself in your room, you can do A, B, and C. Giving them alternatives. And as they become more aware of what their emotions are and what their actions are, that pattern changes and they start to feel better.
Mm-hmm. So essentially you're changing the behavior, and that changes the thought patterns and changes the psychological outlook.
Right.
Now, if you add medication to this, Andrew, and parents and a child needs to be on medication, what should parents be aware of, and how do they assure that this treatment is going to not be abused and going to be followed by the child? And
Sure. You know, I think the first most important element is who you're working with. I think that the community feels that it's very important, the mental health community, to be working with a person who has expertise and experience in working with either children or adolescents, that just a general practitioner or a pediatrician or even an adult psychiatrist generally will not have the experience in identifying symptoms and understanding how to work with someone in those age groups. So that's critical. I think the second step is a careful evaluation and a system of careful monitoring. And then, of course, the practitioner would want to introduce a medication gradually, explain it carefully, help the parents to understand what the medication's about and what to be alert to. Be sure to be very careful in monitoring the medication, particularly in the early stages, and be available and be reachable at all times.
Mm-hmm. Now, in light of the recent FDA reports, how should parents whose children are on antidepressants be proceeding? You know, should they be panicked and worried, and
well,
what should they be doing?
I think, fortunately, they should not be panicked and worried. As people may kind of remember, this started with the British in the summer of 2003, had reviewed about 4,500 subjects that had been studied in a variety of studies. And what they found was an increase in suicidal thinking and in some suicidal behaviors, and they were concerned. And I think that they blew the whistle a bit loudly at that point, although all practitioners knew it was important to monitor kids carefully. Now this information has really been reassessed, and although there are some mild increases in suicidal thinking in children who are taking these medications, the numbers are quite small, less than 1% in most of the studies. They're confined to a few of the medications, and the differences are really not that great. So our recommendation to people who are being treated in our agency is, first, if you're on a medication that's working, you know, don't suddenly stop it. Second, if you're considering medication, consider the medications that have the best track record in terms of statistics. But most important, don't undertake a medication treatment without careful monitoring and psychotherapy at the same time, whereby the therapist is part of the team, working with the parents, working with the child. And we think that taking that approach is very safe and should not discourage people in any way from passing up medication that could be quite helpful.
Mm-hmm. So if someone comes to WJCS as a client for treatment, there's a whole team that would work to assess the appropriate therapies and appropriate treatments for that child.
Yes, usually what happens in our setting is that they will be first assessed by a social worker or psychologist who has an expertise in dealing with children. And then if they're, and they may try behavioral treatment for a period of time before consulting a psychiatrist and considering medication. For the majority of cases, the behavioral treatment works pretty well for kids. In cases where the degree of impairment is more severe, or they've already tried behavioral treatment and the symptoms are not remitting, then they would be referred for a psychiatric consultation, and then perhaps medication would be discussed at that time. Mm-hmm. It's done very carefully, and when they're on medication, they are very closely monitored by the team. So the medical doctor, the psychiatrist, works very closely with the therapist and keeps an open communication and dialogue, and I think that's crucial in order to monitor these possible symptoms.
I think in light of parents being so concerned today, Leslie, you had a philosophy of parenting for resiliency. And maybe some of those guidelines can help parents manage and cope with children who have mental health issues and emotional issues. Can you give a little bit of advice to parents to maximize the possibilities that their children will perhaps avoid depression or avoid having to take medications for depression.
I think that one of the most important principles of parenting for resiliency is really understanding and supporting the child as he or she is, what's called the real child. We all have wishes to what we would like our children to be like, and sometimes they are, and often they're not. So for example, you wouldn't want to push a child who is not artistically inclined, but is perhaps very musically talented. You wouldn't push that child to go to art class or a painting class. You would encourage that child to go to a music class. Same thing, we see a lot of children who are being pushed academically, who may not have the intellectual ability. So it's really understanding the child and accepting the child as he or she is. Another principle is to be predictable and to create a secure environment from which your child can move. By being consistent, by being nurturing, by creating a safe environment, the child then feels able to go out in the world and meet the challenges. One of the other major principles is working on the child's self-esteem, helping the child to encounter success. And that doesn't mean an artificial saying, oh, every time the child does something, oh, that's Picasso. It's because the child will know. The child will ultimately go to school and put his picture next to another kid's picture and see it's not so good. It's helping the child to feel good about what he or she does, and then also skill building. So if you have a child who is not athletic and who feels very badly about that, would be giving the kid, if possible, private lessons or helping the child to develop those athletic skills. So realistically, he's not going to feel bad about himself. So skill building is another principle.
Okay. Well, we only have about 2 minutes left. Margarita, do you have any other guides for parents that can help them bring up children who might be more healthy mentally?
I think one of the key things is keeping communication open, whether it's depression or abuse that might occur, having open communication. So if your child comes and tells you something that's distressing, watch how you react. It's very hard to sort of keep that thermometer in check, but because they will go by how your initial reaction is. So if you keep your cool and react appropriately, they'll come to you again when they have another problem or another issue. So I think that's a really important basis to keep that communication open.
Okay. Well, as we sum up, I think if parents are watching and they're concerned about treatment and medication, what are your last pieces of advice?
Well, I just think to share a recent large study of depression in adolescents found that medications were effective in 70% of the adolescents treated. That medication and cognitive behavioral therapy were effective in 70%. That medication by itself was effective in 60%. And that cognitive behavioral therapy by itself was also effective in the 45% range. So these are effective treatments, and I think that people should have be optimistic that they can be helped and not be scared off by some of the hysteria in the media.
Okay. Well, I thank you all for helping us explain to parents what some of the issues are, what some of the possibilities for other treatments are, and I hope the parents out there will understand how they can best help their children. Thank you very much for your time. Please stay tuned, because in our second half we'll be talking with a parent who has worked with a child who's had problems, and with some social workers who have assisted them in their struggles to find support. Thank you. Welcome back to the Ways We Care of Westchester Jewish Community Services. I'm Dale Wang, Director of Community Relations. WJCS is funded by government grants, UJI Federation, United Way, private individuals, foundations, and corporations. Parents of youngsters with emotional and mental health problems face many decisions and challenges as their children try to cope with school, social, and environmental stresses. With conflicting messages about the effectiveness and risks of medications and treatment therapies, families often do not know where to turn or what to do to help their children. Tonight we have been speaking with WJCS psychiatrists and a psychologist who have offered suggestions about how families might proceed when dealing with a depressed child. In this segment, we will talk about accessing appropriate services and supports. We will also be speaking with a mother who has worked with the mental health system to obtain treatment for her children. I'd like to welcome Kathy Cunin, who is a social worker with the WJCS KICS program at the Martin Luther King Elementary School in Yonkers. Welcome, Kathy. Lakeisha Hunter Ward, who is a parent of a child in the Yonkers school. And Betty Muchler, who is a social worker with Family Ties. Welcome, Betty. So you have heard our discussion in the first half, and we've been talking about the issue of childhood depression and its impact upon the child and the family. Kathy, you're in a school working with children of all ranges of educational and social problems. What are you seeing today? How does the KICS program operate, and what do you see in terms of the issues that children are struggling with today?
Well, the KICS program began over 10 years ago. It was part of the New York State Office of Mental Health. They're an initiative to try to bring services into the community, into the schools to help children and to help families. And we're in the school. It's a mental health clinic that's placed in the school to provide mental health services. And what happens in the school is that kids come to our attention through the school support team. If a child is acting out in the classroom, that could mean anything from walking out of the classroom, from throwing chairs to getting into fights. We've had children that have run out of the building, and they come to our attention. And then what we do is we reach out to the families. We operate a little different than a mental health clinic, however, because we're not obligated, we don't bill. So we don't have to, get a parent in within the first 3 visits and then forget about it and move on. We're able to continually reach out to a family, because a lot of the families are overwhelmed. They have a lot of issues going on, not just this one child. So we're pretty persistent. We make phone calls. We catch them when they're dropping their kids off, when they're picking their kids up. We send notes home in book bags. Most of the children in the school, if not all of them, know who we are. They want to come, even the ones who really don't need our services. So they pretty much harass their parents. Please call, please call. And then once we get the parents in, we explain what the program is. It is voluntary. They do not have to accept our services. But I would say probably 99% of the time the parents do. These are parents that are used to getting phone calls almost on a daily basis. You need to come pick up your child, and just hearing one negative after another about their child in the school building. So usually the parents are sort of relieved when they get to us, and we were like, well, we've noticed him, and he seems like a sweet kid, and we're able to see more of the positive aspects, because we're not in the classroom trying to control 30 kids.
Right.
And from that point on, we do a pretty extensive intake and assessment of the child, and what his developmental issues might have been, how his past experiences have been in the school, and we really come up with a plan. Once we've done the assessment. And it can be anything from just once a week individual therapy with the child, but more often than not, it's running intervention as well in the classroom. Some kids might have a difficult time walking into the school in the morning. There's a lot of activity going on, so sometimes we'll have a child come into our office space first. we'll sort of settle them down while the teacher takes the rest of the kids down and get them settled, and then we'll bring them down. Some kids will get calls, you know, on a daily basis multiple times because they've walked out of the classroom. They've, you know, tipped over tables, you know, whatever it might be. And we try to work collaboratively with the teacher and with the school to come up with both a safety plan and to really help them move forward, as well with the parents.
What kinds of mental health problems are you seeing?
We really see the range. We really, when they're children, depression, you know, it can come out as anger. It can come out as hyperactivity. So children don't exhibit what's ailing them inside the same way as adults do. So a lot of times, you know, what on the surface might look like one thing, very quickly we're able to see is really something else going on. A lot of, you know, the school personnel feel like, well, they can't sit still and they can't pay attention, you know, put them on medication for ADHD. But a lot of times that's not really what's ailing the child. And for some children, just a very strict behavioral program is all they need. You know, just give them some little rewards for doing the right thing and then just keep building and building. For other kids, you know, we then say, you know, this isn't working, something else seems to be going on here. We might ask the parent to have a psychiatric evaluation with our psychiatrist. Sometimes we do psychoed testing as well to try to tease out a little bit more if maybe there's an educational issue that's really affecting their behaviors. You know, so we provide a myriad of services and we tailor it to whatever that child or that family really needs.
Okay, and you also, once you've done this, then you work within the school to to connect all these pieces, and you also connect to supports outside of the school.
Right.
How does that work?
How does it work? It depends from family to family. In Westchester County, there's a network system. You know, and sometimes what happens is, you know, we find that there's so many things that need to be done. We can't do it ourselves. We're a very small staff. We only have 2 full-time staff people and 1 part-time at this point. So what we do is we try to pull in other people that might be able to provide some of the other services. They might need some support at home, be it just even respite so the parent can get out and take a break. Sometimes it's to take the child out. You know, they may need parenting skills. It could be a lot of things. Sometimes we hook them up, you know, the parents trying to get back to work. They've been out of the workforce for a while. We try to hook them up with, you know, programs that can help them with that kind of a thing. So we really tailor it, you know, and we call around, you know, we're involved with the network system. So we go to monthly meetings, so we're on top of what's happening in Yonkers. And we get in contact with whoever we need to hook our clients and their families up with the most appropriate services. Because there are times when our program is not the appropriate service for the issue that's going on.
Okay, and some of these services, I assume, can be WJCS services too,
Yes.
like the respite program, maybe
Right.
Project Timeout, or home health services for parenting support,
Right.
or Family Matters if you need case
Right.
management. So I assume that some of these services become WJCS, or in the clinic,
Right.
you refer parents or
Right.
family.
And sometimes there's older siblings as well, you know, who are also sort of struggling, and they maybe weren't in the Martin Luther King School, so they didn't get our services.
Right.
But they clearly need services. We'll help get them to our clinic.
Right. And we'll come back to Lakeisha's story because it's really a case example of how this works. But I'd like to talk with Betty a little bit, because one of those services I know you refer to was Family Ties.
Right.
And can you give people a little bit of sense of what Family Ties is and what its role is in working with families who are stressed, with children who have emotional and mental health issues?
Okay, well, Family Ties is a agency that works with families that have behavior and emotional problems with their children. Sometimes they also have psychiatric problems with the parents who are suffering from that. And we offer support. We have regular support groups for our grandparents that are caring for grandchildren, for our young parents that are caring for children under 5. We also do regular support groups for parents, as well as we have an education component, which can be parenting skills. We have a resource library for our parents, so that if they need to know anything about some of the behaviors and difficulties their youngsters are experiencing, we can give them that information. And we provide also some respite services for parents. Just this past couple of weeks ago, we provided a retreat for parents, and we took 35 parents away for the weekend. And we gave them a night away from their children, and they got to be up in a campground and enjoy being in the outdoors with a kind of structured program that was very supportive and creative. And I think it gave them new strength to go back and deal with some of the struggles they have to deal with. And that's kind of what we focus on. Plus, we also participate in the network system. And
let's just step back, because some viewers may not be familiar with, when we talk, sometimes we get into the jargon, and you and I know what the network system is, but what is the network system?
Well, in Westchester County, there are 10 networks which are in different communities. And what that really is that when a family comes to us and is struggling with some difficulties, what we can do is set up a network meeting, which involves service providers that are local to the family. And it also invites the family. And what we do is really structure the meeting to really talk about the strengths of the family, what the needs are, and how we can get a plan together, and what people in the room can actually be of help to the family. And from that meeting, we come up with a plan, and then there's a follow-up support meeting, so it's called a support circle. And that family has their own team that meets regularly to help that family. And it works well in supporting families through some of these difficult times. And when their struggles continues and we need a meeting that things aren't working, we can ask for another support circle meeting, which I know you probably are familiar with. And I think it works very well in terms of supporting families, getting everybody on the same page, and building on the strengths the families have, because we do it on a strength-based way, and we build on that.
I just want to back up a little too, because we talk about families, and we know that not every family is mommy, daddy, and 2 children. Who participates in these support circles for what is the family that participates in
the
that?
family can be who the family, or the mom or the dad, or whoever's caring for the child, feels is their support. So it may be a cousin, it may be the neighbor, it may be some social workers that they bring into the room that they feel is part of their support team. It can be all of that, and the families aren't necessarily mom and pop, and it might be grandma who's caring for her grandchild. It could be a single mom, a single dad. And we try to get them to identify who they feel are their supports in the community that can be of help to them, and they can participate in the meeting. So it changes, but it's what works for the family, and we try to do an individualized plan that will help them.
Right. Okay. Lakeisha, let's talk a little bit about your situation. You have how many children?
4.
4 children. And one of those children was at Martin Luther King Elementary School, and that was how you connected to...
Actually, 3 of them.
3, okay. So tell me a little bit about your family situation and how you realized that your child needed help and how you got into our program.
Well, it was a hard situation. It started with my oldest daughter before. She was put in the kids program, and then she had a separate issue, so she was placed somewhere else. Then later on, I met Kathy, and she called me, and as they say, first they do other means in the school first. The teacher talks about it, the counselor talks about it, then they eventually bring the parent in and go, look, this is not working, and we try to do other means. They called me in, Kathy called me in, and discussed about having Jason evaluated. I was totally reluctant at the beginning. I didn't, until the point it got to an escalated situation that it was very bad.
What kind of things was he doing in the classroom?
He was the type of child that he didn't throw things, he didn't tip things over, he just disappeared. You know, he was the quiet. He just went into a shell, and when you weren't looking, he's gone. And in these schools now that have 20 kids and 30 kids, it's easy to misplace a little Jason, you know. So,
And how old is he?
And he disappeared. He's 10 now.
10.
He's a twin. Okay? And he would disappear. So now when he had some place to disappear to was the Kicks office. He didn't leave the school building. He didn't have people worrying him, calling me on my job. He's missing, we can't find him. You know, but no parent wants to hear that.
Right, sure.
You know, when you send your child to school, regardless of the fact, especially when you're not willing to open up and go, my child has a problem, because no parent wants to admit my child has a problem. That's not something that you want to do.
Right.
But when you have supports like the Kicks program, because the Kicks program, and Kathy, and I'm going to keep saying it, Kathy, you know, because, I mean, I'm easy to deal with, you know, because anything that's for my children, I'm for. But like I said, to accept the child has a problem. It went to the point that with Jason, he had to be put in Four Winds Psychiatric Hospital because he went from disappearing to now he wants to be violent. And it was like, he didn't spend a week in school, and it was like, wow. But if I did not have the Kicks program, you know, Kathy and Lori and all of them there to go, look, we're with you. You know, I'm going to tell you how to do it. It's your decision, but we're with you. You know, we're not going to leave your side because you leave the school. We're with you. And they were. You know, they really were.
When Jason was home with you, did you pick up any signs or signals that he was acting out or not acting out in school?
It was harder with me with the first one than it was with the second and third, because Jason, as far as I was concerned, didn't have a problem because he was quiet. You can talk to him, I talked to him, he talked to me. He just didn't do what everybody else. That's what I was in a fog about. I'm like, so what? I didn't think it was a big deal. I noticed it more with the two children after him because they had different signs. Each child is different. I have one child that wants to go into a shell. I have another one that's just, he's loud and he just goes through a crying fit, and you can always see what's going on with him because he's very emotional. Then I have another one that's like, she's from somewhere else. She's a mixture of both of them. So, you know, but with Jason, it was the hardest. I think if Jason would have came after the rest of them, it would have been worse for me, because I would have said, look at these two, look at how they show it, everybody can see it, it's not Jason. So I'm glad, you know, not that it happened, but it happened in the sequence that it did, because it made me more acceptable to it, because Jason's the one, like I said, he was the closest to me.
Now, Kathy, when you pick up problems like this with a boy at what age? 8 or 9 was he?
He was 8. 8.
He was 8. And so how did you begin to engage Lakeisha and help her understand that he had a problem that really needed to be addressed and that you needed to work on together?
Well, as she said, she wasn't willing to go down that path so easily, and it took several months to really get her to buy into the program. And I think what really got her to finally buy in was he connected with me long before he was ever in the program, and then she was kind of taken back because he hadn't been trusting of other people. And so that kind of opened the door a little bit. And, you know, and I think the other thing too was, I mean, behaviorally, we were able to set out for her, you know, behaviorally, this is what he was doing, you know, last year, this year, this is what he's doing. This is a huge change.
A change in behavior as the therapist.
And that really helped to open eyes for everybody, you know, when it came to him.
Obviously, it sounds like you were a little reluctant to work with therapists, and I understand from Kathy that you were reluctant to put him on medication as well. What went on when you were thinking about that, and how did you decide to let your child take medications and have this be part of the treatment?
I got to a point of no return. I'm like, it has to get better. And I was to a point that therapy, because medication was a last resort. They went through the therapy. They went with him connecting with Kathy, which I'm saying, okay, once he connected, I said, oh, it's going to turn around. It didn't. You know, it went completely different. So the next step, and I said, well, this is a stage thing. If I don't like it and it's not going to work out, then we'll have to get him off of it. But right now, I'm at a hope of no return. He's out of school. You know, he did homeschooling for almost a year. I'm like, something has to be done. He cannot stop progressing because I'm stubborn and not letting him get what he needed, if that's what he needed. So comes to find out, he's 10 years old now, and he did need it. He's doing excellent now. You know, he's the Jason that smiles. He never smiled. From the time he was an infant, Jason didn't smile. He didn't talk unless I spoke to him. Now he smiles, he laughs, he sings. He loves Kathy. He still loves Kathy. He's not there, but he still loves Kathy. You know, and he's more social. His thing was that he was not social at all. You know, and giving him the medication, I did not agree with the Four Winds Hospital. I did not like it at all, but I must admit, Four Winds, if they have to be put in someplace like that, is very structured. They're very friendly, they're very kind and loving there to the children. And the environment, it doesn't actually look like a hospital. Like they're in a psychiatric hospital. It looks like little houses, you know. We're away to camp right now. Just that when they're at camp, you gotta know that 24 hours a day they're being observed. So it was a comforting situation when I went to visit him there. You know, it was a comforting situation to see him when I went to see him. First time I actually saw him smile was when he went in. They put him in Four Winds. And that was a lot for me. I was like, well, what am I doing? How is it that he's smiling and he doesn't even realize where he's at? But, you know, along with that, I was having my own problems with the whole situation because that's my baby. You know, like I said. So when I went through my little breakdown, so to speak, it was Kathy again. Or anyone else in the kicks. I can just call and they like, talk to us. I hear it in your voice. It's okay. And, you know, now that I'm going down the line, because now there's Jason now, I have two others now, so now it's like starting all over again, but it's not as hard. Because now I've had a network, what they're speaking about, where everybody, just had one 2 days ago, as a matter of fact, where everyone come together, you know, and they're all there about what's going on with my family. The whole table is about my family, what to do, what's the best thing, what's our strengths, how to make it stronger, what do I need for my relief, and, you know, so on and so forth.
And I think the other important thing is with Jason, it got to the point where he really did need to be hospitalized. And that was heart-wrenching for all of the other children in the family and Mom. And because Mom was more willing when it came to the next two and they started exhibiting behaviors, they got on the medication, they never had to go to the hospital. And so, you know, early intervention, which is a big part of our program, and we can start with a kid as young as 4 years old, if families can get to that point where they can accept it, if it's needed, because not all kids need medication, that it will really prevent difficulty down the road.
When a child is on medication now, what do you do in terms of follow-up and follow-through?
Well, I mean, we continue to see them minimally, you know, once a week, but we usually see them every day, you know, whether it's formally or informally. And then our psychiatrist, Dr. Lisa Aaron, does follow up with them. When they first start, she sees them anywhere from every week as a follow-up, depending on what the medications are, to once a month.
Betty, you mentioned that parents would be able to research and get some advice and support if they're considering if medication has been offered as a possibility for their children. What other kinds of supports does Family Ties give to a family like Lakeisha's?
Well, we have regular support group meetings, which actually many of the families are experiencing the same kinds of issues, and they don't really feel alone. And I think that's one of our families recently said that, you know, that in a meeting, that they really felt that by being with other mothers that are experiencing the same kind of difficulties, that they're not so isolated and they're not feeling quite as badly. But I think Family Ties also helps families with advocacy in terms of mental health issues. We try to educate families about that. We do a little program called spokesperson training, where we train families how to speak up for themselves, whether in a school situation or you know, with a teacher or with a therapist, and we help families do that by videotaping them, by letting them see how they come across, and we do some work with leadership, so that we're trying to help empower families so that they can address some of those issues that they're struggling with and not feel alone.
Okay, we only have about 2 minutes left. What advice would you give parents about tuning in to recognize the signals that their children might be having difficulty? Lakeisha?
That if a teacher or a counselor calls you and tell you that they notice something with your child, get on it right away. I mean, listen to what they say and then observe it for yourself. You know, don't let it prolong and wait until it escalates to something really, really bad, because then it could be a situation that you really can't deal with. You know, and ask for support, because there's support everywhere. You just have to ask for it. You know, you have to ask for it and go, look, I'm open, help me.
Right.
Just don't be ashamed to ask for help.
So you've worked with the network system, you've connected, and now
Yes.
you feel that you're on the right track.
Yes.
Kathy, you have 1 minute. What would you tell parents who are struggling to know whether their child has a problem that's serious enough for professional
Well, I would
help?
tell them to really be involved with what's going on. If they're getting calls from the school, stay open-minded about it. I mean, parents know their kids best, obviously, but sometimes they don't see them in another setting. So parents should go into the school. They should see what's happening, because sometimes I've seen parents just, you know, their mouths drop open. They can't believe it's the same child that they have at home. And, you know, like Lakeisha said, you ask questions, ask for help, and just stay open. And it doesn't mean that you have to go along with what everybody's saying, but just stay open to what people are saying.
Okay, Betty, how about you?
Well, I agree with what Lakeisha and Karen said. I think that we need to really listen to our children, listen to the professionals, and I applaud Lakeisha for actually being able to face that. It took a lot of courage, and I think our families, it takes a lot of courage, and I think that with support, we all can do it.
Right. Well, I thank you all for sharing your insights and advice, and I think that in this world, when it's so difficult for parents to know where to turn and they get advice on TV, this medication helps, that medication helps, that we really need to know that there's help right in the schools and in the community, and in ourselves, you know, to have the resilience to deal with our children and help them find the right support. So thank you all for your insight and for everything you're doing. And best of luck to you with your family.
Thank you.
If people want information about WJCS, please give us a call at 761-0600, extension 205. And Betty, could you give the number for Family Ties?
Well, Family Ties has 5 offices. We're just opening another one in Ossining. But the central number is 995-5238, and that's in White Plains.
Okay. Well, thank you, and good night.